My name is Lynn Fox. I'm a speech-language pathologist from the University of North Carolina at Chapel Hill. And I'm here to present Voices from the Past Informing the Future, firsthand insights from founders of the earliest U.S. craniofacial teams. And I have no disclosures. Here are today's learning objectives. I'll let you take a look. So the inspiration for this presentation came from two events last year. At our last ACPA meeting, I noticed an undercurrent of concern with so many proposed changes in insurance and NIH funding. People were concerned about how we would be able to adapt and continue to provide top quality care for our patients and advance the field through research. A few weeks later, a colleague and I spent a lovely day at Dr. Don Warren's farm, where he regaled us with fascinating stories about the early days when he founded the UNC Oral Facial and Communicative Disorders team, which eventually became the UNC Craniofacial team. I began to realize that as difficult as some of the challenges that were ahead of us might be, those who created the first cleft palate and craniofacial teams had to envision and build this entire field using their own creativity, prowess, and ingenuity. There were so many lessons we could learn from these voices from the past. While we have lost most of these voices involved in the first few cleft palate teams, we still have quite a few people who could provide first-hand accounts of the forming of the first craniofacial teams in the 1960s and 1970s. I knew that I needed to record some oral histories with some of the people who were part of these early teams. As I created this abstract and delved through all the technical and practical aspects of a project like this, ACPA lost more and more of these voices, including, sadly, Don Warren's. I will always regret missing the opportunity to record his account in his own voice, and I dedicate this presentation to him and to those on whose shoulders we stand. Today, you will see videos of many of the early founders and members of some of the first craniofacial teams. But first, I want you to hear Dr. Warren's story in his own words. Fortunately, Don sent me his account of the founding of the UNC Craniofacial team just after our visit last April. If you knew Don, you know what a wonderful storyteller he was. I will not do his words justice, but I know he wanted to share this story with you. Full disclosure, I have condensed this account to fit within our time constraints, but here are Don's words that he shared with me. In 1963, when I started at UNC, I was warned in advance that the plastic surgeon who was doing cleft surgeries believed dentists had a very limited role in cleft care. Orthodontics and restorative dentistry care were all that he sought. After great outcomes for several patients with my speech appliances and subsequent speech therapy, Dr. Peacock realized at last other clinicians were useful in treating patients with clefts. We started having monthly meetings and talked about setting up a world-class center. We decided on a model that was ideal for a rural state. We knew that while primary care could be provided in Chapel Hill, follow-up by pediatricians, otolaryngologists, speech therapists, hearing specialists, psychologists, and others were often unavailable in rural areas. At that time, there were only 3 MS-level speech pathologists in the state. We decided that our role must also include training for specialists involved in cleft care. However, for the present situation, we needed to provide most of the care in Chapel Hill for many of our patients. Thus, a residential program was needed, as well as a protocol for our patients to receive a comprehensive, multidisciplinary evaluation at the time of their first visit. We then had to find a facility where those children needing daily care could stay. Storybook Farm, run by the Barretts, was used for a few years until the state said it couldn't license them for 24-hour care. A few weeks later, I ran into 2 friends, the Dickersons, an elderly couple that owned a horse farm just outside Chapel Hill. Now, Don was always into horses and horse farming. He jokingly asked if they would board children along with their horses. They responded quickly and positively. He was a builder, and he said he could build a facility in 3 months that met all the regulations. Don mentioned that we didn't have the funds, and the Dickersons responded that they could handle it. They also said that they would care for the children as well and would only charge actual costs. 3 months later, Wonderland was completed. One side consisted of a 15-bed female area and the other side a 15-bed male area. In between, there was a commercial kitchen, a dining area, and a very large recreation living room. Outside, the Dickersons built a very nice area for the children to play. Finally, we had a beautiful facility where we could house up to 30 children while they were being treated. I've worked at UNC 21 years and never knew this. The Dental Foundation bought the team a very large van for transporting the children to the dental school. Dr. Peacock and Dr. Warren badgered the State Department of Education for funds to employ a teacher in what was to become the Little Red Schoolhouse. The School of Education provided graduate students to help with the educational needs of the children. Many of the kids came to us behind in learning. They were able to move most of them up a year while they were with them for 3 months. And as an aside, local newspaper accounts at the time reported that children's speech improved 30 to 50% by the end of a 10-week intensive program. The town of Chapel Hill adopted our kids. Some of the children were dropped off with only the clothes on their back. A group of women made certain that they were well clothed while there. The fire department would often take the kids for a ride around town with horns blaring, and the kids loved it. Dean Smith, the beloved basketball coach, sent his players to interact with the kids on a regular basis. It was not unusual to see Michael Jordan, Sam Perkins, or James Worthy with the kids. The families of many of our patients did not have access to transportation for appointments. We arranged through the various state police and fire associations to have the local deputies bring families to Chapel Hill. The kids loved it. Riding in a police car or fire van provided lifetime memories. The residential program lasted from 1964 until 1982. There were several reasons why they decided it was no longer needed. Residents from all the specialties involved in care had rotations through the center and learned the concept of team care. We encouraged the university to add a graduate program in speech and hearing. The final factor that led to the discontinuation of the program was the university legal officer realizing we were never covered by an insurance policy. Obtaining a policy was not financially possible. Ignorance and luck helped us get through 28 years of residential care without mishap. To understand what this experience was like from a patient's perspective, let's hear Linda's story about how she became one of the first patients at the UNC Craniofacial Center.
They knew something was not right, but they could not put their finger on it. And my mom kept telling them, Linda is not speaking like she should. There's something wrong. And they kept telling Mama, they said, well, Miss, you have to understand. Linda was born a little early. And so it's going to probably take her longer to develop those skills. Well, my mom, I guess I'm like a mom, she would not take no for an answer. So finally, the head cardiologist at pediatric cardiologist at UNC told Mama, okay, this is what we're going to do. I'm going to take you to a clinic that deals with speech disorders. But the deal is, if they can't find anything the matter with her, you got to drop it and leave it alone. And Mama told him, said, I'm not going to promise you that.
Yep. I'm here to say Linda is much like her mother. Now, that clinic dealing with speech disorders was the duly formed UNC Craniofacial Center. Linda's speech difficulties were, in fact, related, amongst other things, to a submucous cleft palate. Once her treatment plan was finalized, Linda became one of the first patients to stay at Storybook Farm while she received surgery, speech therapy, and education.
Storybook Farm was a farm that was located about maybe 20 minutes or so from Chapel Hill. And so I think it started in September that we went to the, and when I say we, there were 10 kids that went to the farm. And Mr. Barrett, he drove us around, and I love animals. I thought, hot diggity dog, this is going to be so much fun. And he drove us around, and told us all about the animals. And he told us, he said, everybody is going to have a chore. Now, it doesn't matter to me what animal you choose, but everybody is going to have a chore. The first supper we had, I will never forget, was a sloppy Joe. I never had sloppy Joe. You know, this was a treat with French fries. We had, like I said, we had chores. And every day we had to make our beds. And then we went and we ate breakfast. And then we all piled up in this minivan. And we went to the Craniofacial clinic. And that's where we got our schooling.
Now let's hear from more members of early craniofacial teams about what it was like working on these teams as they were first forming or transforming from cleft palate to craniofacial teams.
I came through the Duke General Surgery program, the plastic surgery program. My dad founded the team, and cleft lip and palate and craniofacial surgery was an important component of training at Duke University Medical Center. So I kind of fell into it from that standpoint. I've been involved with it as a teenager along the way, watching some of the things my dad did. And that was one of the things that pushed me to be a plastic surgeon, because I felt that within basically an hour, you could make a greater change in someone's life by doing a cleft lip repair than probably any other operation that I know of. And that was not just rewarding, but it was something really sort of inspirational to see what you could really do for people from a reconstructive standpoint. You know, the things that I remember about it, they're kind of interesting sidelights. So because of my dad's oral surgery background, he was interested in basically maxillary growth and basically positioning of it, preceding the NAM. So we, in the dark ages, before the vivarium was what it was, we had a colony of cleft lip and palate beagle dogs. He sent the word out to the veterinarians that he was interested in. I can remember with a Chetwood syringe as a teenager feeding these puppies because they wouldn't survive any other way. And then he would subsequently, as they matured, he would do different surgical procedures to try to correct the underlying palate and lip abnormalities. That was sort of interesting from a very early age.
Dr. James Lehman was initially turned down by Akron Children's Hospital when he attempted to start a craniofacial team because the hospital did not see a reason to hire a speech-language pathologist. So he started the team in a local medical office building a half block away from the hospital, completing all surgeries at the Children's Hospital.
And I tried to point out, you know, you can't take care of these children and get them through if you don't have a team. It's a team procedure. It's no individuals. And they weren't used to that. Mm-hmm. But the Litchfield Rehab Center was really happy. And so we went there and we stayed there for over 4 years. So, and in 79, we moved back to the hospital and they agreed to pay for the administrative assistant the speech pathologist, and the audiologist. The plastic surgeons, the orthodontists, and the ENT physicians did not get paid. And I think they figured we were already making a good income, and that we were not in a financial problem. And so we just accepted that. And I didn't think it was an issue anyway.
In 1976, when Dr. Kathy Cap-Simon joined the University of Illinois craniofacial team, the field of pediatric psychology was fairly new. Psychologists who were associated with craniofacial teams had, to this point, primarily engaged in research and intellectual assessment. Dr. Cap-Simon was one of the first to broaden the scope of the craniofacial psychologist to add intervention and advocacy for patients and families.
So when I started, there wasn't really a format, what to do in the clinic. You know, how does the psychologist fit into a busy medical clinic? And I sort of had to find my own way there, trying to decide, you know, how do I see families? What do I tell them about myself? Why are they seeing a psychologist? They came here because their child had a cleft or had a craniofacial condition. So I really had to decide on a format for introducing myself and working with families and understanding what they needed, essentially. So I started that by interviewing a lot of the adolescents. I kind of wanted them to tell me, what's your history? What was it like for you coming to this clinic since the time you were a baby? One of the adolescents I interviewed was a young woman by the name of Colleen, and one of the first things she told me was, you know, I have an older sister and she's working as a hostess in a restaurant. No one's ever going to hire me to do that job. You know, which sort of broke my heart. You know, look at me. She had a bilateral cleft. And it was a fairly decent repair, but it was still a bilateral cleft with all of the residual scarring that came from it. And she was very, very concerned about how she would be perceived in the workforce, which gave me a direction to think about, you know, how do young people who have facial differences think about themselves? There wasn't a lot written back then, okay, about children with facial differences, about anyone with facial differences. They often didn't go to school because, especially if they had more severe conditions, Public Law 94-142 didn't exist, had just been passed, and so their services for special needs children were just beginning to come in school. Prior to that, families were told, keep your child at home. We don't have anything to offer you.
They were actually told to keep them at home. Oh, that's interesting. Wow.
Mm-hmm. Yeah. Especially if they were more severely disfigured. Yeah. The other part of the Colleen story that I discovered later was really heartbreaking. Sam Brzezinski had a large database. He had big folders that he kept in the database where he had, you know, photographs and X-rays and all the impressions that he took impressions for every child, every visit. Okay, so that because he was a great researcher to study natural growth and development. Well, I looked at Colleen's folder, and one of the pictures in that folder was her newborn picture. And it was sitting, the picture was sitting, or was a picture of her in her crib, and in front of the picture was a little sign that said, "Do not show baby to mother."
Oh.
Yeah, mm-hmm. Yes. Do not show baby to mother. It was a very severe bilateral cleft, very protrusive maxilla. And I mean, it just broke my heart, again, to see something like that and think about what was it like for that mother?
Sometimes the new team's location would create unique challenges. Holmes County, Ohio has the largest Amish population in the world. So the Akron Craniofacial team needed to find ways to serve these patients who often traveled by horse and buggy and who sometimes had issues with modern conveniences.
The first thing we did, or at least I did, was because the Amish people are, well, some of them are earning good money, but a lot of them are farmers and that. So what we did in our office was we said, the first time you come, there's an office fee. And after that, because you have to pay to get a vehicle to bring you up, so we're not charging you anymore. And so that was a big help.
Teams sometimes struggled with protocols for when and how to seat patients and families, as well as how to obtain the best services for patients in the schools.
We had two faculty members at Northern. One was a marriage and family therapist, and the other one was a speech language pathologist, that they wanted to integrate those principles in providing family-centered care for children with speech and language problems. We decided we wanted to take that also to the assessment part with our team. Those in the medical professions were not on board. There's a lot of discussions like, well, we can't have open conversations. What if there's a controversy? What if there's a difference of opinion? They shouldn't hear that. And of course, our reaction is like, well, if I'm sitting in a room, I want to hear it. It was a part of it. So it was a struggle.
It was just the beginnings of special education services, and so all the individuals working there were young and enthusiastic, and they really wanted to provide services for the children. So it wasn't as hard in the beginning. The only roadblocks, at IEP meetings were the finances from the administration. We can't afford these services. That sort of pushback, but not from the staff, not from the people working with the children. What happened gradually is with the introduction of the tier service, as you know, we actually had a little bit easier time getting some of the beginning services for children. If they needed reading services, we could get them on the lowest tier level and just get them some support services in the classroom. What we had difficulty with after that is if they needed more intensive services, getting children to qualify for special education to get an actual ongoing individualized or small group services. That's when we ran into problems in the latter years, because everybody wanted to keep kids at the lowest tier if possible.
Now Linda will describe the discrimination she experienced at school because of her differences.
I looked at my mama and I said, Mama, if they can't do anything else for me, don't take this from me. I'm begging you. I want to talk like other children. I want to be able to express myself and not be torn to pieces. Because during that time, Lynn, when I was in school in Lenore County, a teacher we were sitting in a circle, and she would let other kids read paragraphs. But when it got to me, she would only let me read one sentence. And I went home every day crying because I felt like I was being isolated. And I felt like that I'm never going to amount to anything, because a principal even told me, he said, I don't know why your mom is wasting this time taking you to Chapel Hill, because you're never going to amount to anything. But I was determined I was going to learn how to talk. I was going to be able to express myself. and I was going to be a go-getter.
Having teams of different medical professionals interacting as equals was difficult for some team members to accept. So it was up to the team leader to address these issues to maintain highly functioning and effective teams.
Well, there were the occasional people who were not born team players. They were born stars, they thought. And there was sometimes some conflict between the team players and the stars, the would-be stars. But with Sam Brzezinski, you either did it his way or you didn't do it. He, shall we say, dispensed with people who couldn't seem to learn the concept of team player. And that while the ones who stuck around, the team players, were the ones who learned what an enormous joy it was to work with these kids and their families and the co-team players.
Since craniofacial teams were much larger than cleft palate teams, finding ways to fund research, salaries, and patient care was a significant challenge. Craniofacial centers had to rely on multiple funding sources and sometimes had to get creative.
You had to write grants that would propose studies, and NIH or NINCDS paid for the studies. So that also paid for patient care, sort of on the sly. But the amount of money that was obtained by that means was very significant. And institutions that couldn't pull off grant writing and grant subsidy, getting your grant paid for, had lots of trouble.
Yes, most of them were supported and brought to us through the Division of Specialized Care for Children. They had a very active network throughout the state, and they would identify the families and bring them to they didn't bring them to the clinic, but they would support financially bringing them to the clinic.
So they would
you know,
help
of
with
course,
the transportation?
They helped finance transportation. Yes, they did. They helped help the families get to the clinic. I don't remember all the details of how they did that, if it was through reimbursing them for the actual medical care, which is what I think they were doing. Medical care, not actually transportation, but that helped because a lot of families didn't have insurance that covered the services of their child. I talked to families who would say that their medical insurance would cover all of their children except the child with Apert syndrome, for instance. Okay, so yes, I did. As I said, families did struggle with insurance coverage for their children, and DSCC helped many of especially actually all the families. Any family in need was helped through their services. They paid for orthodontic treatment. They paid for medical care, so it was very helpful for them.
What they decided to do was to give grants in aid to 3 centers in the state, which meant that you gave the services on a sliding fee scale basis. You were paid ahead. It was sort of like a form of capitation, early capitation, and that there was no longer fee for service. So you wouldn't charge for hospitalization, you wouldn't charge for surgical procedure, you wouldn't charge for speech therapy, but you provided it as part of this program. And that you billed third party first, and then it was not covered by third party, then was subsidized because you were subsidizing salaries and therapy services with the grant. Well, one of the major roadblocks, and still is a roadblock, has to do with billing, because you can't bill multiple CPT codes on the same day with the same diagnosis. So that's an issue. And we've overcome it by working with our managed care department and the way we bill. So we don't bill through physician billing, we bill through hospital billing, which has to do with percentage of charges. And that's sort of a little different in every state that you are in and how it's managed.
So if you could pay for it, you could do it. There really wasn't anything that was a constraint. So if you could put a team together and you could figure out how to make those individuals be financially viable in their daily activities, then this could be something that was an outgrowth of what their overall expertise was. So there wasn't a lot of support coming from anywhere else. You had to do other cases to generate the margin to do these things. Standard story, no mission, no margin.
You know, a lot of rural North Carolina families didn't have a lot of resources, and there wasn't clear coverage for this kind of care. And so I remember times where the doctors needed to fork up some money to pay for a child's care. And we used to bring our checkbook with us to team meetings when we knew there was going to be a request. And it was one of the things that sort of amused me and actually pleased me was the doctors really cared. And when somebody came along that couldn't afford care, their attitude was children, especially children with special needs, don't get a chance to pick where they're born, or don't get a chance to pick the family or the nation. And the team felt that every child needed a chance. And so their attitude was, if the state can't pay for it or won't pay for it, we'll just have to chip in and help make it happen. And that was so refreshing to me. I had never seen that happen. You know, usually you go to doctors and you get the bill. And yet they were saying no child gets turned away. It could be a child from Honduras or Mexico. It could be a child from a poor rural area in North Carolina. They were all treated very much alike, and they were not sent away. So one of the big roadblocks was the cost.
ACPA and what used to be called the Cleft Palate Foundation, which was integrated into ACPA in 2017, has helped shape and benefit cleft palate and craniofacial teams. Initially, ACPA focused on professional practice, research, and education, while CPF focused on patient education and fundraising. Arguably, the most impactful of ACPA and CPF's endeavors were the establishment of the self-assessment for teams in 1990, which would evolve into our current ACPA team approval process and parameters of care, with its first edition in 1993. Three of the key influential people who helped envision and create these guidelines were Gip Seaver in his role as president of the Cleft Palate Foundation, and Ron Strauss and Kathy Capsimon, both who served as presidents of ACPA.
There was some criteria for listing as a team that existed before that. It was a self-study. Nobody believed anybody was telling the truth, and it wasn't necessarily outcome-based. So there were some parameters there. There were some criteria to be able to be listed on the website, but nobody liked it. So if you were in a major medical center, you had one concept about how a team should run, but if you were like in where I was at, it was a much different. We were doing something that was much different than, let's say, at a major medical center. So nobody liked it, and nobody trusted anybody else. It's like, I'm okay, but I know you don't do it right. So that's what we talked about. We needed to have something that was more outcome-based, would have some basic criteria to say, if you're going to be listed, you have to meet those criteria. So we actually brought in a consultant who had worked in credentialing.
And so it took years of working on this. Simpler in the beginning, got more complex. Some things got, redone. And of course, it's been reworked now multiple times, as it should. And now it's become a kind of, they don't call it a credentialing agency, but in many regards, you can't use the ACPA logo on your website or your letterhead unless you've gone through the team standards review, and it's become tighter and more effective. But there's no doubt that got its start around a few centers that had developed a scientific and clinical orientation to care. And it was the first time that I really realized that there were a lot of cleft palate centers that didn't really even know where to begin in the craniofacial realm. And then there was this like phenomenon of craniofacial care, and we were starting to see some operations among French surgeons that, were amazing and very challenging. And we needed to make sure that the ability to do the high tier craniofacial care was cultivated, and it hadn't been cultivated in the United States in much of a way. It really needed to be stimulated. And so there were standards for cleft palate teams and there were standards for craniofacial teams. They were really quite different.
So that, it began with the parameters, and then when we got to the team, what do they call that now? The accreditation. It's the accreditation of teams. We were able to. We also were able to include psychological services as one of the criteria for accreditation of a team, and that was a major. It took a lot of discussion, because there were people who understandably worried about the financial implications of that for both for the families if they had to bill insurance, but also for the clinic in supporting it.
ACPA encompasses more than team guidelines and standards of care. It is the professional home for so many of us. Marilyn Cohen describes the importance of ACPA and how it has shaped professional and patient experiences with team care.
I think one of the main things is to realize that that the American Cleft Palate Association is more than just an academic association. It's looking at the role of patients and families. It is looking at how professionals view their own profession, and that how they can interrelate, and that the friends that I've made over the 50 years are precious through the association, and that that you can call somebody else. Call somebody up and say, I have a patient with such and such. What's your advice on this? And it may not be in your own bailiwick, in your own hospital or your own team, but you can call somebody. So I would call somebody in Philly, or call somebody in New York, call somebody in Delaware, and say, what's your advice on this? So I think that the relationships that have been fostered through the Cleft Association, and just through treating patients for as long as we treat patients is really key.
When asked for their advice for current craniofacial team members, our trailblazers replied with a wide variety of topics, including effective team functioning, healthcare advocacy, and creative ways to add team members. Oops.
I think you have to be creative. You have to look how you can work things out and be creative, and even if it means that you're meeting on Zoom, because we've learned that we can do that, and people are seeing people in individual offices, but to at least come together at least once a month or once every 2 months in a capacity where your team is talking to each other. And I think one of the main things is a level playing field, that all of your specialties have to feel like they have a voice, that it's not dominated by one profession or the other.
So that was a really radical thing back in the day,
Yeah,
correct? I mean,
very
it still
definitely.
is. It still is in many
Very
situations.
definitely. But I think it's a little easier with the younger group than it was with the older group. But it's getting on a first name basis and understanding that everybody has a piece to play.
It's maybe hard to do in some regards, but children that have these problems really need to be cared for in a team atmosphere. It's going to may have a major difference overall in the outcome. Individuals that do things the same over time tend to do them better. And teams tend to communicate and provide for better insight as to how patients really should receive their care. So now my thrust for this would be a push to, on a state or regional basis, to have the quote carriers, whoever the fiscal intermediary is, only let these children be cared for in centers of excellence, and make the case for not just their outcome, but they don't care so much about outcome, but cost, and how this is effective for both the carrier and the child, all aspects. I think that should be a major thrust. It just doesn't make sense to have children cared for in other than centers for excellence.
You know, I think we have to be proactive in advocating for the healthcare, especially for the cleft and craniofacial population. They're a very, very needy group of people. We have to continue supporting legislators who are willing to go out of their way to try to assure continued health care benefits for this population of patients. In terms of professional advice for people who want to become involved in cleft care, my advice is hook up with a comprehensive team and do what you know how to do to the best of your ability.
I can certainly say that to obtain psychology services, mental health services for the clinic, I would reach out to universities if you're in a larger area. If you're in a smaller, more rural area, look to the mental health clinic. Try and develop a partnership with them where they can have someone rotate through. It's a way for them to provide a service to the community, but also it's a way for them to increase their clientele as well, if needed.
Be nice to people, number one, and you have to follow nice, you have to hire nice people. And nice is not something you can teach. It came from mom and dad, and if it's not there, forget it. Look on for somebody else. And you know, we have, I had a couple of get-togethers with some of our old, you know, nurses and secretaries that worked 25, one person 35 years. And to me, that's having that kind of continuity. I mean, it rubs off on everybody, the patients, the families. They see the same people and the warm feeling that they get from them. And you can't buy that.
Mm-hmm.
It comes from mom and dad.
Yeah.
And so I think that's one of the most important things you can do.
If a parent comes to you and says, I can't understand my child when they're speaking, what's going on? Don't brush them off. Listen to them. Because parents always know when something is not right. And I know that firsthand. I've been through that not only as a patient, but as a parent.
You may be wondering why there are people missing from these interviews, and there are. There are so many other important people who should have been interviewed as part of this project, but in the end, there's only so much time in the day, and I apologize that to those I was not able to include. I hope that someone else takes up this project and continues to record these histories. This represents a full circle moment for me as my last ACPA presentation before I retire, and encompasses both my first graduate degree in American history and my very rewarding career in craniofacial team care. Every one of us in this room is here because of the vision, drive, and dedication of those who came before us, who created and established effective team care for patients with craniofacial conditions. We owe it to our past and present mentors and to our present and future patients to build on this past, to create an even better future for our patients, families, and colleagues. Thank you very, very much. But I would ask that we have several of our interviewees here today. Their names are highlighted, the ones who are here today, and they are here available to answer any questions that anyone has. So the floor is now open for questions. Thank you. Yeah, we need Linda. We need Linda. Why don't we have our four that are here stand up and face the crowd, if you don't mind. Thank you so much. I guess you can go now. Thank you very much.